I'm Anna Peeters, Head of Obesity and Population Health at Baker IDI. I was also past President of the Australian New Zealand Obesity Society for the last 4 years. Today in Australia, around 27% of adults are living with obesity, and then another large proportion are living with overweight. So in some age groups, like middle-aged men, over 2/3 are living with overweight or obesity. And in children, the problem has increased similarly over the last 30 or 40 years, where about a quarter of children now are living with overweight or obesity. One of the really important issues at the moment in the developed world, so across almost every high-income country, we know that those people who are living with greater socioeconomic disadvantage, whether that's lower income or lower education levels or living in a more remote area, have a much higher risk of obesity. So in Australia, we know that the sort of fifth of the population with the greatest level of disadvantage have about double the rate of obesity compared to those adults who live in the areas with least disadvantage. So I've just returned from a study tour supported by a Churchill Trust Fellowship, in which I was able to visit America, the UK, France and the Netherlands. In America, there are very large disparities which are mainly along race, ethnic and income lines. In the UK, they have similar disparities to us, where every marker of education and income is associated with a greater risk of obesity. So one of the great challenges with obesity prevention is that we're trying to do a number of things at once. We know that really it's critical to get obesity prevention right. The rates have been increasing since the 1980s, and we're really not seeing signs of a decrease anywhere around the world. And we know that that has very large economic and health costs for our populations worldwide. One of the elements of my study tour was really to explore a theory that we've developed, that when we're looking at population prevention for obesity, that perhaps those interventions that rely more on what we call agency, so that's the individual's purposive drive, if you like, to do something, those interventions, which are things like education, information, social marketing, are more likely to benefit those with higher education, higher income, higher literacy levels. Whereas those interventions, which we might call more structural, so these are ones that change the environment in which we work or live or play, such that individual agency really isn't addressed, those interventions are more likely to be effective across a whole range of socioeconomic groups. As an example, it's really important that we have nutrition education in schools for children, because that's a critical component for being able to lead a healthy life. But we know that for particular kids, giving them only nutrition education isn't going to solve the fact that perhaps those healthy foods aren't available at home, or those healthy foods are too expensive for their parents to buy, or even perhaps they don't fit with the social norms of their family or community groups, and they might even get teased by trying to change their food preferences. So unless we can address those barriers at the same time as we provide school nutrition education for kids, then it becomes less likely for more disadvantaged children to really be able to work with that new capacity. One of the really exciting things on this study tour was meeting the people involved in policy direction from Philadelphia. It's the poorest of the 10 largest cities in the US, and they have really large disparities in health, both by race, ethnicity and by income. So it's something that's really top of their mind. And talking to the head of their policy section, it was really clear that he thought that this idea of a combination of agency and structure was really critical, and in fact had been how he had been acting implicitly. So as one example, they have a strong focus on schools, and they have an education program, SNAP-Ed, which is really focused on providing nutrition education to children. So they had worked a lot to make sure that that was relevant to their population. But at the same time, he realised, as we were talking about before, that if they did not also address the barriers to healthy eating, it was really difficult for a lot of these children. So at the same time, they came in with nutrition standards throughout the whole school, so that the food that the children were surrounded by at school met what they were teaching in their classes. So his was a really nice example of trying to devise policy that took into account both strengthening the individual's skills and knowledge and then changing the environment to enable that behaviour. At the same time as we are pushing as hard as we can for really well-coordinated obesity prevention action, I think what my work and my study tour has really illuminated is the need to think more carefully and cleverly probably about how we combine these policy actions to ensure that those at greatest need are reached effectively and not left behind.